Just realized I need to start the recording. So, she currently practices at our Quakertown site, seeing patients 5 days a week. And I just want to do a little housekeeping. There are multiple different sign-in forms. The CME is for anybody looking for CME or Pennsylvania PT credit. There is a nursing sign-in specifically for nursing and also a specific nursing certificate. The other certificates are for anybody else. So PT, athletic training, and CME. There's also a separate sign-in for New Jersey because New Jersey has special requirements. So, without further ado, Dr. Redmond.
Thank you. Good morning, everybody. I'm going to be talking about chronic pain and pain in general. Before we do that, the obligatory disclaimer: I have no financial interest in any of this. These are our learning objectives. I'm going to be talking about the prevalence and the impact of chronic pain. I'll also review what we know about pain science, current treatments for chronic pain, and how we can identify patients who might benefit from a neuroscience approach. Sorry about that. The actual number of patients with chronic pain is hard to determine. Estimates vary greatly. I saw one source that said that every single man, woman, and child living in each of those highlighted states is the equivalent number of people in the United States who have chronic pain. The National Health Interview Study in 2015 found that 11.2% of adults reported having daily pain. And that doesn't account for children. And there's also a large number of children who also suffer with chronic pain. Chronic pain is a huge burden on the healthcare system because people with chronic pain tend to overutilize healthcare services, and the cost runs probably in the billions. And unfortunately, even though so many people suffer with chronic pain, medical professions have not been very successful at treating it. Usually, the primary treatment offered for people with persistent pain is pharmacologic management, generally opioids. We all know the dangers of opioids. More than 15,000 deaths were associated with prescription opioids in 2015. And I think it's also worth mentioning that the FDA reports that annually about 3,500 deaths occur from side effects associated with nonsteroidal anti-inflammatory medications. So the CDC came out with new guidelines in 2016. I don't know why that's skipping ahead for me. And they recommend non-pharmacologic management. And some of the things that they specifically mention are cognitive behavioral therapy and exercise. So I think that's the perfect opportunity for physical therapy because that's the kind of things that we can do. Unfortunately, for us to be successful, we need to have a better understanding of pain sciences, and we need to be able to apply current treatment approaches. And there's so much research that has come out in the last 20 years, but a lot of people aren't using any of it. I think that chronic pain needs to be viewed as a complex illness, whereas in the past, medical professionals have failed to even recognize it as a legitimate condition. So I'm going to start to talk about what we know about pain science. Pain is the body's alarm system. Its purpose is to protect tissues from damage. It's a complex system. We have ascending nociceptive pathways that travel to multiple centers in the brain. Those brain centers analyze the input. A network of neural connections determines what should be done about it, and then our response is modulated through descending pathways through the spinal cord. Brain pain starts in the brain. It's the brain that decides whether we're going to feel pain or not. It analyzes the information that comes in. It decides, is there damage to tissue? If there's potential damage to tissue, then we sense it as pain. The intensity and quality of pain that we feel is the result of ascending nociceptive pathways and descending modulating pathways. I think it's important to understand the difference between nociception and pain. Nociception is not pain. Nociception is defined as the stimulation of nerves that convey information about potential damage. Sometimes that's referred to as danger messages. Pain is the subjective perception that results from the transmission and modulation of sensory information. So we can have nociception without pain, and we can have pain without nociception. It's important to understand that pain is not an accurate indication of what's happening in the body. Pain is not equal to tissue damage. Pain is felt when the brain decides that danger to tissues exists and action is required. This gives you an idea of the complex network of neurons in the brain and the various areas of the brain that are associated in pain perception. Pain perception involves sensory and motor areas, areas associated with cognition, concentration, fear, memory, learning and conditioning, autonomic regulation, and stress. Pain is modulated by many factors. It involves not only somatic factors, but also psychosocial factors. Pain also depends on the context of the situation. It's the brain's judgment of what we need to do about it. So for example, if you walk around the house and you stub your toe, it's going to hurt really bad. If you're running from a grizzly bear and you stub your toe, you're not even going to know what happened because your brain's going to decide that it's more important to get away from the bear than it is to feel pain from your toe. There's a lot of examples of people who have suffered traumatic amputations, maybe a shark attack or a bad car accident, and they report that when it happened, they really didn't even feel it. And that's because the brain doesn't allow them to feel pain in that situation. Survival is more important at that point. So it's really the brain's determination whether we feel pain or not. And I think we need to be careful with that. If we start telling our patients it's all in your head, then they take it the wrong way. It's not, to say that isn't that we have control over it. They're not making up their pain, but it is the brain's determination. So pain follows the need to protect tissues. When there's an injury, pain increases. We have inflammation, we have scarring, we have remodeling. And then as all that healing process goes on, pain should diminish, like you see in the blue line there. Pain should go away as the tissues heal and things get back to normal. With chronic pain, which is the red line, we have the same injury, the same inflammation, the same scarring, the same remodeling. Healing happens, but the pain persists. So chronic pain is pain more associated with nerves. Acute pain and the normal progress of pain is pain associated with tissue. The nervous system excels at learning. It always changes and adapts. And that's usually a good thing. It's how we learn new information. But with persistent pain, the level of sensitivity of the nervous system increases. And the longer these nerves receive stimulation, the more sensitive they become. Over time, less stimulation is required. The nerves begin to send more signals. Nerves in the spinal cord actually build more receptors. So then we have this heightened sensitivity of the nervous system. We develop central sensitization. We might see things like hyperalgesia or allodynia. Changes occur in the brain's body map. In our brain, we have a map of all of our body parts. And distortion of that brain's map of the affected body part can occur in chronic pain. Sometimes that's referred to as cortical smudging. The area corresponding to the body part might become larger, less defined. When that happens, it can alter motor responses, it changes proprioception, and it changes sensory discrimination. And this is an important concept because it explains the basis for some of the problems that we see with patients with persistent pain, and it also is the basis for some of the treatments that we can use to help them. Changes occur in the brain with chronic pain. The bottom picture shows a healthy brain. In a healthy state, areas of the brain exist in equilibrium. When one area is active, the other areas quiet down. In chronic pain, all the areas of the brain are active at once. In particular, researchers have found that the prefrontal cortex never shuts down. And this increased prefrontal cortex activity suggests that chronic pain states have stronger emotional and cognitive components than acute pain states do. So there's decreased sensory processing and increased emotional and cognitive processing. So these changes have been shown to occur in patients with problems like phantom limb pain, chronic regional pain syndrome, but they're also seeing that similar changes occur with other musculoskeletal disorders like chronic low back pain and osteoarthritis. But the good news about neuroplasticity is that the system can change, and if it's changed in a maladaptive way, it can change back. So in order to address these nervous system problems that occur in persistent pain, treatments need to be directed at the brain and the nervous system. Some of the treatment approaches that can be used are neuroscience education, cognitive functional therapy, graded motor imagery, and sensory discrimination training. And I'm going to give you a little bit of an overview of each of those. Pain neuroscience education is explaining to patients the neurophysiological basis of their pain. Patients come and they want to know, why do I have this pain? What can you do for me? Is it ever going to get better? They want to understand what's causing it. And in persistent pain, they need to understand how their nervous system is working. And that's the goal of neuroscience education. It teaches people that pain does not equal tissue damage, movement is not going to be harmful to them, and it teaches the concept of neuroplasticity, that things can change. There's been a lot of research done on neuroscience education. Research shows that patients are able to understand the basic concepts of neuroscience, and it's shown better outcomes when they do understand the physiological basis of their pain. Pain neuroscience education has been found to decrease pain, actually improve functional performance. There was one study where patients were given a session of neuroscience education, and one of the measures was passive straight leg raise. They did nothing physically with these patients, just neuroscience education, and they actually improved in passive straight leg raise at the end of the session. It's also been shown to decrease perceived disability and decrease catastrophization. Results are variable, and teaching methods are variable as well. Some sessions are one-on-one, hour-long sessions. Some are group sessions for 3 hours. But in any case, all of them have shown positive results. It's also important that pain neuroscience education be delivered as part of a multimodal approach. It's not in and of itself enough, but it should be part of other physical therapy interventions. Cognitive functional therapy has also been shown to be effective for patients with chronic pain. And cognitive functional therapy is a little difficult to explain because it encompasses a lot of different components. But basically the idea is that they target the patient's fears, beliefs, behaviors. It involves individualizing the treatment to that particular patient. There's a cognitive component that identifies things such as negative beliefs about pain, fear of movement, protective behaviors, and a functional component that identifies movement impairments and teaches better movement strategies and coping strategies. Cognitive functional therapy might also include things such as graded exposure or graded activity. Graded exposure is about gradually exposing the patient to activities that they're fearful of. And progression through it depends on patients' fear ratings. So you would choose an activity. Maybe they're afraid of walking. They would start walking at a short distance, a slow speed, something they're not too fearful of. Once they can do that and they feel okay about it, then you increase the intensity, the duration of it, always based on their comfort with it. Patient education has to be a big part of that in order to decrease their fear associated with musculoskeletal symptoms and movement. Cognitive functional therapies like this downplay anatomical explanations for pain, and they emphasize coping strategies. Graded exercise or graded activity is a little bit different. This works on a quota attainment method. So it doesn't try to abolish people's pain. Instead, it tries to increase their functional level. So they're encouraged to gradually do more and more in spite of their pain. And to use this approach, we have to accept that maybe people's pain isn't really going to completely go away, but we can teach them how to manage it and function better with it. Treating patients with chronic pain through a neuroscience approach requires a shift from a biomedical injury-based model to a model that views pain as more of a multifactorial biopsychosocial disorder. A pathoanatomic approach is not always as effective with these patients, and it may actually increase fear-related behaviors. And it's sometimes difficult for healthcare providers to provide these kind of treatments because we've all been educated in an anatomical model. We are taught to look for the pain generator and treat the anatomical part that's the problem. And for a cognitive functional approach to work, we need to be able to get away from looking for the pain generator. We also might not have to recognize that we're not going to completely get rid of people's pain, but rather teach them to function with it. And there's a lot of positive evidence for cognitive functional therapy, but the results are variable, and I think that's because there's so many different methods and ways that it's done. There's research that shows that a cognitive functional approach works well for patients with chronic low back pain. And actually with chronic low back pain, a pathoanatomic approach may not be relevant, particularly given the poor correlation between spinal pathology and pain. A pathoanatomic approach also doesn't explain how pain occurs in the absence of tissue injury. Someone with chronic low back pain no longer has any tissue injury going on, but yet their pain persists. Pathoanatomic approaches also don't address fear-related behaviors. And we know that pain-related fear is a strong predictor of outcome in low back pain and should be addressed. This was a study published in 2013 that compared cognitive functional therapy to manual therapy and exercise in a group of patients with nonspecific chronic low back pain. They had 121 patients who were randomized to either the cognitive functional therapy group or the manual therapy and exercise group. Both of the groups improved significantly across all measures, but they found that the cognitive functional group had superior outcomes to the manual therapy and exercise group immediately after treatment, which is a 12-week period, and they also still had those benefits at the 12-month follow-up. What I thought was even more interesting is that the satisfaction rates in the cognitive functional group were 3 times higher at 3 months and 5 times higher at 12 months. Another intervention that people might be more familiar with is graded motor imagery. Graded motor imagery is a 3-phase program. It begins with laterality training or left-right discrimination. The second phase is explicit motor imagery, and the third is mirror therapy. This began with treating patients with phantom limb pain and then went on to be used for people with chronic regional pain with CRPS. And since then, it's found to be effective for patients with back pain, osteoarthritis, and many other musculoskeletal disorders. It's a graded process. So each of these phases activates a little more areas of the brain, and it should be done in the order that you see there. So the first phase is laterality training. Laterality training is the ability to distinguish right from left sides of the body. And research has shown that healthy people are much better at distinguishing right and left than are people with chronic pain. If we remember, changes occur in the brain with chronic pain. We have changes in our body map in the brain that occur with persistent pain. And this impairs proprioception and body image. So laterality training helps to normalize that. The way it's done is either with flashcards or, like you see on the left there, or on the right, there's an app that can be put on an iPad or a phone, a tablet. And people are asked to look at images of the body part, whichever, if they have a foot problem, they would look at feet. And they determine, is that a right foot or a left foot? When they perform left-right training, it activates cortical networks that involve representation of the limb, and it involves premotor areas of the brain. The goal in laterality training is 80% accuracy and a speed of 2 seconds or less for hands and feet. Normal for necks and backs is 1.6 seconds or less. They recommend that laterality training be done in different environments and different stress levels. It requires a clinician to guide the patient through it so that they progress properly. For some people, just looking at these images will produce pain. So people need to know how quickly to progress and what intensity and duration of these treatments to do. It's recommended that they have good performance, 80% accuracy, good speed, for a week consistently before they progress to the next phase. They should also be able to perform under stressful conditions with good accuracy. So the next phase is motor imagery. Motor imagery is watching movements or imagining movements. Motor imagery affects the primary motor cortex and the secondary motor cortex. It also activates mirror neurons, which is a classification of neurons that fire in response to watching movement or imagining movement. For example, if you have an athlete, they might imagine their sport. If you have a pitcher, maybe they imagine what movements they would go through to perfect the perfect pitch. So in addition to actually performing the movement physically, people do imagery to improve their performance. And this is a way of retraining the brain and activating those motor cortexes without actually moving. This should also be graded. So in the beginning, people might only look at someone moving. And then once they're able to do that without provoking their pain, they might move on to actually imagining the movements themselves. The final phase is mirror therapy. Mirror therapy kind of tricks the brain into seeing the painful body part move without feeling pain. So you can kind of see in the pictures there, it can be done for just about any body part. The painful part is hidden behind the mirror, as in that first picture. So say the right hand was the problem. That's hidden behind the mirror. The person looks at their left hand and the reflection of it in the mirror, which then looks like their right hand. It's very important for the illusion to be complete with this. It has to actually look like the right hand so that the brain sees it that way. And this should be graded, and that maybe in the beginning people just look at it. And if they can look at it and it's not painful, they might start moving the left hand, the non-painful hand, and watching the reflection move in the mirror. As they get better with that, they might actually start to move the hand behind the mirror. And they keep progressing in this way until they can eventually move the hand behind the mirror without it producing pain. There aren't a lot of real hard and fast guidelines for graded motor imagery. Consistency is very important. I've seen things that recommend a minimum of 7 training sessions per day, which seems like a lot. We have in our clinic, on our iPad, we've put on a Recognize app, which shows different pictures of different body parts so they can do laterality training. I recommend to my patients that they do this on their phone or tablet so they can do it as part of a home program. And it could also be done with pictures or flashcards if someone can't do it that way. But the advantage of using the tablet is that it will grade them at the end. It'll show them so many pictures, and it'll tell them what their accuracy was, and it'll tell them what their speed was. So they get immediate feedback on their progress. It's very important, as I said before, that patients are guided through this process. And it's also important that they work on it in different environments. So if they are doing, for example, laterality training, they might do it at home in a quiet space at first, but then maybe they go outside in the park or to a mall where there's a lot going on around them. It's important that the environment around them is varied. This particular study was looking at visualization of the back using mirrors, kind of an extension of that mirror therapy idea. They looked at 25 patients with back pain and had them perform repeated lumbar movements in all directions, either looking at themselves in a mirror or with the mirror covered where they couldn't see the movement. And what they found was that the patients with chronic low back pain had less increase in pain, and their pain resolved faster when they were able to visualize their back during movement. So I think that's interesting because that's something that we might be able to use with our back patients. And the last thing that I'm going to talk about treatment-wise is two-point touch discrimination. Two-point touch is the ability to perceive two separate points as separate points. It can be tested with a caliper, or I actually use a paper clip. You would use the caliper and see if they can distinguish 2 points at this distance, and if they can, move it closer and closer and closer, and see how close you can get it and still have it be perceived as two separate points. Research has shown that people with back pain have impaired ability to discriminate two separate points. They've shown that there's a difference between back pain patients and healthy controls, and they've also shown that patients with back pain don't have a very good perception of two-point touch in the area of their pain, but it might be normal in another part of the back. This also goes back to those changes that we talked about that happen in the brain, where our sensory discrimination is altered. So we know that body image is disrupted in many chronic pain states: chronic regional pain syndrome, phantom limb pain, low back pain. I just told you that patients with low back pain have decreased tactile acuity, and also that decreased tactile acuity has been associated with decreased lumbopelvic motor control in patients with low back pain. And to me that explains a lot, because one of the things I always like to teach my low back pain patients are pelvic tilts, and they can't get it. And I've never really figured out why something so simple they just can't figure out. But the reason that they can't get it is because they don't have good proprioception, they don't have good sensory discrimination. So retraining that may actually help them with motor control activities. This was an interesting study. It's not a very compelling one. It was only 6 patients with low back pain, and they used 10 healthy controls as a comparison. But they were looking at distorted body image in patients with low back pain. So they did 2 things. They measured 2-point discrimination, and they asked people to draw a picture of their back, what they felt their back to be. And you can read, there were the instructions that they were actually given, but basically what they were told, they were given a partially completed picture of a back and told to fill in where you perceive your back to be, not where you think it is, but what you actually feel. And these were the results. So the circled areas are where these people had pain. The horizontal bars are their 2-point discrimination, and you can see that it's much larger in the areas where their pain was. And people who had unilateral pain, you can see it distorted on the side of the pain, but not on the non-painful side. Also interesting is that in these 6 patients, all but one of them failed to complete the picture of their back in the area where the pain was. They all universally said they couldn't feel it. They didn't have that sense of where their back actually was. And I just think that's interesting because it shows that how people's perception is altered in chronic pain states. This was a more robust study. It had 45 patients with low back pain, 45 healthy controls. They looked at tactile acuity and lumbopelvic control. They assessed tactile acuity using 2-point discrimination, and they assessed voluntary motor control. They found that 2-point discrimination was larger in the patients versus the controls. They also found that patients performed worse on lumbopelvic tests than did the healthy controls. They found, not surprisingly, that the 2-point discrimination was positively related to worse performance on voluntary motor control tasks. So they concluded that training tactile acuity might assist in recovery and restoring normal performance after back injury. So if we know that persistent pain has a strong neurological component, we need to treat that in order to get these patients better. But not everybody is going to benefit from a neuroscience approach. We need to be able to identify those specific patients who will. We also, I think, need to be able to do that as quickly as possible. We're here to talk about chronic pain, but I think these concepts are important when we see people in an acute state as well. There was a study of patients with whiplash that showed that they had abnormal nociceptive processing in as early as 7 days or less after their injury. And we know that these changes are indicative of poor outcome. So if we can identify them early, we may be able to prevent some people from going on to have chronic pain conditions. Some nervous system changes occur as a normal process with acute pain. We have primary hyperalgesia, which means pain in the area of the injury, and peripheral sensitization of nociceptors in that area. That's normal. It hurts and we leave it alone and it gets to heal. What's not normal is when we develop secondary hyperalgesia. In other words, we start to have pain that extends beyond the area of the original injury. This is associated with increased responsiveness of the dorsal horn neurons, and we said earlier that these neurons become hypersensitized, actually build more receptors, and then we start to have these problems which lead to central sensitization. Central sensitization is one way that we can identify patients who might benefit from a neuroscience approach. Central sensitization is characterized by heightened sensitivity to a variety of stimuli. Sensitivity to mechanical pressure, chemical substances, light, noise, temperature. Any of the things that you see in the top list there are characteristic of central sensitization. And a lot of these are things that we can pick up on just interacting with our patients. I've had patients that come to therapy with dark glasses on and they refuse to remove them because the light, indoor light, bothers their eyes too much. That's a sign of heightened sensitivity. Any of these in and of itself, though, is not diagnostic of central sensitization. But if you see 2 or 3 of them, then that starts to indicate a heightened sensitivity of the nervous system. Years ago, I had a patient who refused to lay on any of our mat tables because she claimed a chemical sensitivity to the wipes that we use to clean our tables. And this isn't because she had a reaction to them. She told me this on day 1. She would bring a sheet from home. We would have to put the sheet on the table so that it would be a barrier between her body and whatever chemical residue might have been on our table. And I know what a lot of you are thinking, but before you start labeling this person as psychotic, maybe we should see things like that as a sign of heightened sensitivity and look further for signs of central sensitization. I also had a patient recently who wore dark glasses all of the time, never took them off. When I treated her, I had to pull the shades on the windows down around her. I had to pull the curtain. I had to turn off the overhead lights because light bothered her so much. She had a multitude of problems. We were treating low back pain and we had her on traction, which was actually helping her, but she couldn't tolerate laying on the traction table in our clinic because the noise around her bothered her so much. So she would bring noise-canceling headphones so that she wouldn't hear the surrounding noise. When you start to see things like that, that's someone who has a heightened sensitivity of their nervous system, and that needs to be addressed if that person's going to get better. The other bottom list of symptoms are things related to central sensitization. They're not definitive, but this particular patient also had fatigue. She had sleep disturbances. She had concentration difficulties. She had numbness and tingling and swollen feeling in her limbs, even though they weren't swollen. So all of these things are indicative of central sensitization. And they're things that if we pay attention to our patients, we can probably pick up on pretty quickly. Some things in the patient history might give us a clue to central sensitization. If someone has had a local pain condition prior to their current injury, that increases their chances of developing central sensitization. An abnormal disease course, which would be maybe a more chronic condition, someone with rheumatoid arthritis or a chronic whiplash disorder, something that's been going on for a long time and is maybe relatively stable at the time, but yet the symptom area increases. Secondary hyperalgesia. and the severity of their symptoms increase, in spite of the fact that their condition is relatively stable, or maybe in some cases even improving. Another sign of central sensitization is that person who comes to you and in the history, I've had multiple treatments, so I've seen a whole lot of people, nothing helps me. That's someone that maybe we need to look at a nervous system disorder and not just a pathoanatomic problem. During the physical examination, there are things that we can do to measure for central sensitization. One thing is pressure pain thresholds, and there are devices that you can use to measure that. It's important that when we talk about increased pressure pain thresholds, we're talking outside of the area of primary nociception. So somebody comes in with an elbow problem and they're very sensitive in their shoulder. That's not normal. And I think that it's not necessary to use sophisticated equipment to evaluate that. I think in a general routine examination, as we do palpation, if someone has increased sensitivity in an area that doesn't make sense, that is a sign of central sensitization and secondary hyperalgesia. You can also evaluate their sensitivity to heat and cold. It should feel like the temperature that it is. It shouldn't be painful. Neurodynamic testing might be another clue to central sensitization. One study showed that in patients with whiplash, if they had bilateral loss of elbow extension that was greater than 30 degrees and was also associated with pain, that indicated central sensitization. And finally, increased pain perception in response to exercise can indicate an inhibition of antinociceptive processing. And that's an important thing to consider if we're doing a graded exercise program with our patients. It's also important to consider with fibromyalgia patients who don't respond well to high intensity exercise but respond better to lower intensity exercise. Poor response to treatment. If we do something with a patient that should be a pain relieving thing and they feel worse afterward, that could be indicative of central sensitization. In particular, manual therapy joint mobilizations have sometimes been shown to exacerbate symptoms in patients with heightened sensitivity, particularly if we use high velocity joint mobilization. And ischemic compression can also create problems for these people. Trigger point release doesn't always work well in the presence of central sensitization. Some other things to consider when we're trying to decide who might benefit from a neurological or neuroscience approach: psychological distress, poor coping skills, elevated fear avoidance behaviors. All of these are associated with poor outcomes, and all of these are indicative of patients that might benefit from more of a neuroscience approach. There's a lot of outcome measures that can be used, and I don't have the expertise to go through every one of these with you, but they're available, they're out there. If anybody wants to better quantify any of these things or wants to have a way of documenting progress in these areas, this breaks them down according to what they're best for. The first group for catastrophization, the second, fear avoidance beliefs, self-efficacy, and then finally there's a central sensitization inventory. And I would say one final word, and that's just to be careful how we talk to our patients, because sometimes the way that we say things can increase their fear, particularly when we use medical terminology that they don't understand, might make things sound worse than they really are. But sometimes when we use what we consider to be layman's terms, that can provoke fear too. Telling people that your knee is bone on bone, that sounds terrible, and that can increase fear-related behaviors when they think something like that's going on. I had a patient a couple weeks ago who told me somebody told her her spine is disintegrating. If someone tells you your spine is disintegrating, that's pretty scary. So we can actually feed into these fear behaviors if we're not careful about how we talk to our patients. I think the words that we use with them can inspire confidence in us and can increase hope for their recovery, or we can create fear. So choose your words wisely when you're talking to people. That's all I have. Does anyone have any questions?
What does a typical treatment look like for central sensitization?
I would probably begin with some sensory discrimination training with them. I might do some desensitization exercises. Sometimes if it's painful to touch a body part, we'll do desensitization where they might lightly stroke that body part. Once they're comfortable with that, maybe do it with something rougher. We do graded things. If you took like a silky fabric, like say I have hypersensitivity in my forearm, I can't stand anybody touching my forearm. Maybe just a silky fabric, something that should feel nice, and watch it. Visualization, I think, is helpful with these patients too. And then once they can do that and it doesn't hurt anymore, go on to something that's a little rougher, maybe a cotton fabric, stroke it, maybe terry cloth, work their way up. Always visualizing it and not going to the next step until they can accomplish the first one without pain.
You said temperature. Is it hot or cold or both?
Both. Both. Either one can be perceived as painful when it's not.
Great job, and thank you very much for presenting. My biggest question on this, I know I've tripped up on this in the past, is how do you have that discussion with the patient that your pain is not related to a tissue injury or something like that, but is, for lack of better words, in your head? It's
all in your head. Yeah, you have to be really, really careful with that. And there's some really good resources out there. There's a book called Explain Pain. It's written by Butler and Mosley, which I try to refer people to. Unfortunately, it's a very expensive book and it's out of people's realm. But I've used that as a way of helping them. There's some free resources out there that describe the neurophysiological basis of pain. And I've used those as a workbook with patients sometimes. I really emphasize with them, and you're absolutely right. So many people with chronic pain, they've been told before that you don't have a problem, it's all in your head. And you start talking about, pain is in your brain, and that's the first thing they think. And I always tell them that's not what we're saying. What we're saying is that it's your nervous system, and your nervous system has changed. And I start to talk to them about neuroplasticity and how that it can change back. And yeah, it's a hard conversation to have. And I think that the other part of that is that you have to really have a good rapport with your patients, and they have to trust you. You can't have that conversation if they don't trust you, because they're going to view you as just like that other medical provider that told me that it was all in my head. So definitely developing a trust and a good relationship. Anything else? Yes.
So one thing to add, so there's another book that I do refer patients to. It's only $15. It's called Why Do I Hurt? I do refer that. And then the question for you is, what makes your decision on when to use what type of treatment? Is it based upon the patient's presentation, or?
It's definitely based upon the patient's presentation. I try to incorporate some neuroscience education into my treatments. We spend a lot of one-on-one time with our patients. So I try to, as I'm maybe doing some manual therapy with them, I try to start to explain some of the neurophysiological basis of their pain, little by little with them. Some people, low back pain patients, I do sensory discrimination. I do the 2-point discrimination. If I find that's impaired, I start to work on that. One thing I'll do with them sometimes is trace letters. They should be able to identify letters. So trace, letters or numbers on their back, and what letter or number is that. And I find that if they have unilateral pain, the side that's painful, they can't do it, but the side that's not painful, they can. So I'll work on that with laterality training. I'll try with people that I suspect it might be an issue with. If they do well on it, then I might move on to the next phase, or I might decide that that's not their problem. But I think some of it's trial and error and just getting to know your patient and where they're. I've done a lot of things with mirrors lately with low back patients too. I find that just visualization in the mirror seems to help them a lot. Yes?
During this whole process, is the patient allowed, or is it recommended that they take their meds as ordered?
Yes,
I've had a number of patients that label drug seeking, or that they require a higher dose of meds. So do they take these meds, or do you slowly wean them off of them?
Medication prescription is out of the realm of practice for physical therapy, so I don't intervene with that. I would encourage people to use as little medication as they can, and I encourage them that there are other pain relieving methods out there other than medicine. And I hope that when they come to therapy and we do things, they do feel a little better when they leave, and that helps them to see that there are ways that they can manage their pain. A big part of physical therapy is a home program, and I always try to find something that they can do that relieves their pain, and then give them that as a home program. And hopefully as they have those means of pain relief, they have less dependency on medication. But I don't tell them what to do with their medicines. Yes?
Has a lot of these treatment modalities been evaluated in the benefits of like a hospital setting with acute pain? Because we know that untreated acute pain leads to chronic pain.
Exactly. That's a good question. I don't know of any research that's been done in an acute setting. I do know that the sooner you intervene, the more benefit you're going to get. So you might be able to, I think you can pick up on some of those signs. I have seen people pretty acutely that I know already are developing central sensitization because they have secondary hyperalgesia, or they have pain that just doesn't make sense. And I think when you see those people acutely, we should be trying to intervene that early, and maybe education is the first thing we should do with them. I think if we can stop it in its tracks, then it doesn't go on to becoming a chronic problem. And I think that's just so important, is really to not think of this as chronic pain, but think of it as just an abnormal pain response, and let's do something about it as soon as we can.
I'm a patient that I had back pain in the past, and I went and I received outpatient physical therapy. So for you, you made a statement that your patients come in and they generally say that they've had a lot of treatment in the outpatient setting and they're used to, different modalities and different exercises. How do you engage those patients in a complete change of thought process? They think they're going to come in for additional modalities, exercises, different machines to help their back pain. And I know a lot of it is education on the part of the therapist and the patient's acceptance for that, but they've had a history of what they think therapy is, and now this is a complete different direction that you're going in. And what do you usually find is the buy-in of the patient, and then with the buy-in, how quickly do they progress and make any gains?
I think I don't think their expectations are that they're going to do the same thing they did before necessarily, because if it didn't work for them before, well, sometimes that is their expectation, but they also come in thinking, yeah, you're going to do the same thing that other guy did, and it didn't work. It's not going to work this time either. So I try to tell them, I'll ask them what was done for you before in physical therapy, and then I'll tell them, well, I think I'll take a slightly different approach than that. I think that there are some other things that haven't been tried before that might work for you. And I think if we can, and we have to be honest with our patients. I'm not going to tell somebody I can help them if I don't think I can help them. But if I think I can help them, I make sure I tell them that. I say, you are in the right place. I have some other things that I can offer to you that I think will work. And I think that this is going to make a difference for you. And if you can convince them that you really do know what you're talking about and can help them, then it makes all the difference. And I think people are receptive to that. I actually think people are receptive to something different more than the same old. One of the biggest problems that I have is the patient that comes in because they have chronic pain, or maybe it's not even chronic, maybe it's more acute, but they have a problem. They hurt their back and they need an MRI because the MRI is going to be the be-all end-all to their problem. And the only reason they're coming to physical therapy is because somebody told them that they have to have 6 weeks of physical therapy before they qualify for an MRI. They're the difficult ones, because then you have to convince them that the MRI is really probably not going to make any difference one way or the other. And that's a real hard buy-in there.
How do you document differently than a typical patient that would get range of motion exercises, stretching, manual therapy to this particular type of patient? How do you justify your continued services?
Well, I don't do neuroscience things alone. I'm still doing range of motion and some kind of home exercise program and some kind of manual therapies. So I incorporate anything else into it. I don't do formal pain education sessions where I would just spend a dedicated time to that. But as I'm doing a manual, I might start to discuss it, or maybe while they're on ice at the end of treatment, I might discuss it or give them something to work on. I incorporate those things into the rest of the treatment. And then I'll document that I provided some pain neuroscience education, or we worked on laterality training and they had 50% accuracy on their involved side, or whatever. Anything else? Okay, thank you very much.
Please make sure you guys sign out and pick up your certificates and drop off your course evaluation forms. For anybody watching online, thank you for watching, and please email me for a quiz so you can get credit for this. Thank you very much.